Good morning, folks. Good morning. Thank you for hanging with us through the end of the 2024 NEMSIS V3 implementation meeting. Thank you for joining us. A little frosty this morning. Hopefully some folks got out this morning and could take a quick brisk walk. All right. I uh, will begin by just sharing. Often we provide the evaluation code for this meeting as the very last slide before you leave for the day. And it's very hard to take some time to actually provide us with some feedback that would help us to improve this meeting for next year. So we're putting that QA or that QR code up a little bit earlier. If you could take some time and just evaluate the hotel, how the NEMSIS TAC did, the quality of the presentations, the other things that would really help us to be able to improve what we do from year to year. So if you could take some time to do that, that would be wonderful. You may have noticed there are some goodie bags and soda that are down at the table. They'll be there from now until the end of the meeting. We'd like you to take one of those as you're leaving and traveling today, as you can have a little nutrition while you're traveling. I'm going to go through the agenda for today as well. Much of it was listed as a panel discussion, but we have some topics that we'd like to cover. We'd like to just kind of cue you into those so you can be thinking about those. This morning, to start with, Brooke Burton is here. Her day job is with Salt Lake City Fire, but Brooke has a lot of national responsibilities as well. And Brooke works very closely with NEMSIS. So she has graciously offered to give us an update on where NEMSIS is going, the things that they're doing now. The other topics that we hope to be able to cover, Eric and Alan Aguayo from the National Registry are going to be talking about a national provider ID number. We'll also be talking a little bit about post-crash care funding and potentially the funding that might be available for blood transfusion. Eric and Casey will be talking about that. Casey from the TAC is going to just provide you with some information regarding resources that are available on the NEMSIS website. We also have talked a little bit about extending our education opportunities to clinicians. And so both Eric and Kevin are going to be talking about that as well. We also want to get a feel from states if there have been any integrations of FARS data collection and NEMSIS data collection. Jeremy is going to be leading that discussion. I'd like to talk a little bit about some training opportunities that we can provide. We try to provide those on a monthly basis. I just want to get a feel for if there are other training topics that you think we could offer you or your clinicians or others within your state that could be valuable. Some folks have asked if Eric would be willing to review the timeline associated with the blood transfusion rollout, the schematron rule, and some other kind of educational products. And so Eric will talk a little bit about that. All right. Before I turn it over to Brooke, come on up, Brooke, if you want. Would love to have the NEMSIS TAC staff, if you could stand for just a minute. Yeah, finally, I just want to recognize this group of folks. Everything that you've seen that's happened over the last 4 days has been organized by these fine folks over the last 6 months. So if we could just thank them for their activities and what they provided, incredibly valuable.
Good morning. I am really excited to be here today to talk to you about NEMSIS. It's a project that's near and dear to my heart. I'll tell you a little bit about me. My name is Brooke Burton. I'm a paramedic. I've been in EMS for about 30 years. My day job is with Unified Fire Authority in Salt Lake County, just here over the hill. I quality improvement for them, controlled substance management, and other duties as assigned. I think we all have those, right? But I do a lot of national projects. So I work with NEMSQA. Right now, I'm the president-elect, and I represent the National EMS Management Association stakeholder group in NEMSQA. So just to tell you a little bit about how that's set up, we'll get into that in just a minute. Now, how many people here know about, let's see, I'm just going to figure out how to advance here, know about NEMSQA? Like, what is your understanding of it? Are you completely clueless? If you are, raise your hand. If you have no idea what I'm talking about when I say NEMSQA, okay, a couple people. And how many of you are just kind of starting to get some awareness around what that is? Like, oh, maybe I've heard it a couple of times over the course of the last few days, and I know a little bit about it. And how many of you feel like you're rock stars and you're participating in NEMSQA efforts right now? A few. Okay, great. So we got a little bit of a varied group, and that's what we're really trying to do is get out to some of these conferences and talk to you about what NEMSQA is and how you can be involved in it. So a little bit of history. In 2014, NHTSA got a group of people together called EMS Compass, and they wanted to develop some performance measures for EMS because there were a lot of states and other groups that were kind of putting things together, but there wasn't anything that was really organized and national. So that was funded in 2014. That project funding kind of ran out, and we decided we wanted to continue that work. So it got kind of morphed into the National EMS Quality Alliance, or NEMSQA. And that was funded for a little while by NHTSA, but we knew we had to have it be more self-sustaining as well. And so we decided to put together stakeholder groups. So these were associations that had some, different players in EMS. So stuff like National EMS Management Association, American Ambulance Association, places like that, that all got together and decided they were going to help fund this project and so they started the NEMSQA for what it is there. And in 2019, they were set up as a 501c3 nonprofit. And in 2020, we actually got a lot of work done because COVID took away all of our social lives. So we had more time to work. So we were able to really put together some good performance measures, figure out good processes, how we were going to do this work in a really thoughtful way. In 2021, we released our first measure set, and we did some implementation and tried to really get those out there to the public. In 2022, we started our first collaborative project, and we'll talk a little bit about the collaborations in just a minute. In 2023, we released our second measure set, and we started doing work in those few years for some different states and other organizations as well. And then now we're starting a new airway collaborative project, and we'll talk a little bit about that in a minute as well. So these are a lot of the different groups that are involved in NEMSQA. Like I said, we have a lot of stakeholder associations. You can see kind of their logos there, IEFF, NEMSP, NESEMSO, a lot of different associations. We also have EMS agencies that can join now, as well as federal and state partners, and individuals can have memberships as well. So our agency members really span across the entire United States, which is pretty exciting. We have them across the globe across the states. And as you heard the other day, we had some state partners. A gentleman, I don't know if he's still here, mentioned the state partnerships that we have as well. So you as a state organization can join. And that's a kind of a new category, but we really feel like it's an important one. So our goal is improving patient outcomes through the collaborative development of quality measures for EMS and health systems of care. And that's what we're really about. It's all about the patient. It's all about doing better for the patient. And all of the aims and the things that we think of are about improving that patient care. And you can do that at any level of EMS. So it can start with field providers all the way up to the national level. And, for this group, the states can really look at getting involved. They can look at helping support measures, reviewing the measures that you have available, and developing different quality performance improvement projects for your state. So you can do those as a group in big collaboratives, and we can help teach you how to do that. And one thing that I've noticed is that we've been trying really hard to just get quality people in EMS agencies doing that quality improvement work. States can support that. It can go beyond just saying we want somebody to be reviewing charts. That's like the very basic. But having processes and having protocols and having people that can help encourage EMS agencies to do this quality improvement work and show them how and work on it collaboratively, NEMSCO can help you with all of that. So our first measure set is posted on our website, and I'll have a QR code for that so that you can get in and look at it, and we'll send you all these slides. But our first measure set that we released in 2019 was around a lot of trauma, safety measures, hypoglycemia, respiratory measures, seizure, and stroke. And then in 2023, we really looked at focusing more around trauma and airway. We also have, again, some other measures in there around syncope, but you can look at all of these, like I said, on our website in a lot of detail, so I won't get into too much detail today. We also collaborate with other organizations that are doing different projects to develop quality measures around their projects. So Florida, we worked with Florida to create 56 measures for their state in the Fair Measure Development Act. And Florida has graciously made those available nationally. And so you can find those again on our site and links to those. The American College of Surgeons worked on a field triage for injured patients guidelines, so new trauma guidelines, and we worked with them on updates and performance measures around that. And NEMSIS recently did an evidence-based guidelines measure development project around their research and work on best practices for airway. So we're involved in a lot of those projects. Our measurement development process is really complicated, and I'm totally not going to get into this screen at all because there's people way smarter than me that help make the sausage as far as how all of that is put together. But what I wanted to show you with this slide is just to show you that it's not an easy process. It's not just saying, oh, I think we're going to look at this today. We really, really dig into the research and we see what is best practice, what has really good evidence behind it, and it goes through a multi-step process before we say, this is a measure that we're going to support and put out there and say that people should look at in their agencies. And it's different than research. Research is trying to figure out what we should do. Improvement is knowing what we should do and how do we get there. So it's a little bit different in that regard, but that's why we have this process is to look at all that research and say, these are the best things. We know they are. We should be looking at them in our agency, and how do we work together to implement them and make them happen. So we also have operational definitions for each of these measures on our website. We want to make sure that people know how to use them, how to measure them properly. And they're, a little bit complicated. They have a lot of details in them. So you can go in and review those as well. Because we want to make sure that we're, not measuring oranges to apples. So we want to make sure that people are on the same page. And even more so, we want to be very specific and say, we want to look at Granny Smith apples to Granny Smith apples. We want to make sure that those are very, very specific. And so you'll see in all of those documents, operational definitions. The other thing that's nice is there's also some technical documents in there. And those have kind of the story or the why behind the measure. So when you're talking to stakeholders and you're trying to get them engaged in improvement process and explain to them why these things are important, they can, you can read through this and it will say, this is the reason, this is why we should be looking at this. This is why it helps patients, and it will help you use your data and tell that story so that you can get people excited about these projects. NEMSIS has also helped create a dashboard on the public dashboards on the NEMSIS website that show the first set of NEMSQA measures. So you can go in and see all of those on that dashboard. That's one great place where I, in my agency, was able to take my data and compare it to other agencies nationally, which was pretty interesting to see just kind of how that performance looks. And that's all available there on that QR code, take you to the NEMSIS site. Clay, do you know when the second set of measures is going to be available on the dashboard?
Within the next year, I'd say. Yeah, probably spring, I would imagine. Yeah.
Okay. Yeah, so we're working to get that second measure set built in the dashboards, and that'll be exciting to see when that comes out. Okay. So yeah, state-specific version of that dashboard. And if you can get that information out to your agencies, I think that's really helpful. A lot of agencies don't even know that that dashboard's there. And, you know, they're working in their silo and they don't, a lot of people ask me, I want to be able to benchmark. I want to do this stuff. And that's one great way to do it with information that's already available. And so that's part of what we want to try to do is provide measurable ways for EMS agencies to improve. And, you know, we talked a lot about comparison and benchmarking yesterday. And I'll say that like that makes me a little bit nervous because if you ask Brene Brown, who is one of my favorite researchers out there, she says comparison is the killer of creativity and joy. So when we talk about benchmarking, it's like, oh, do we want to totally destroy our joy? Because if you look at your numbers and you're comparing only, right, and you're doing poorly, how is that going to make you feel? Maybe I'm just going to want to hide my head in the sand and not do anything. Maybe I don't even want to look at my numbers anymore, right? Or if you're a rock star and you're like, oh, I'm great. I'm at like 50% and everybody else is at 20. Well, are you just going to be like, I'm good enough and I don't need to work on that other 50%, you know, or I don't need to be creative? So one of the things that we really tried to focus on when we're talking about benchmarking, when we're talking about sharing data and looking at all these dashboards is how do we use that to collaborate instead of compare? And that's really what we're trying to focus on at NEMSIS is the collaboration around the data. So we started these projects, we call them equip projects. They're quality improvement projects that are a collaborative of many agencies. And we started out with reducing red lights and sirens use in EMS because of all of the measures that we have. That one has the very best evidence to say that the risk is not worth the benefit in many cases in those types of calls. So we put out a call to agencies across the country. We had about 50 agencies that span the US in all different service types. And we worked together for about a year and a half on a collaborative improvement project. And we tried to see, you know, what happens if we reduce our use of lights and sirens? How do we do that in a community so that our stakeholders understand it and can get behind it? And are there any effects that happen, you know, that we aren't aware of when we put in those projects in place? And we collected a lot of data. We did a lot of looking as we did these improvement projects. And we put together a great packet of information for people who are able to, you know, to take that information and implement that project at their agency. And then this year, we've started an airway project. So there was a lot of looking at airway management, effective airway data collection, making sure that we're monitoring end-tidal CO2 and other things around that, making sure our patients, if we're doing RSI at our agencies, aren't becoming hypoxic. And there was a lot of information put out by NEMSIS on that. And so we decided that that was going to be our next improvement project collaborative. And so we've been working on that this year. We just started and had our first meetings this last month. We have 57 agencies in this collaborative, and they're all across the country, including Alaska this year. So that's pretty exciting. Yay. So we are, you know, hopeful that we can start gathering data. That's kind of where we're at right now at the agency level in this project is just gathering the data and then being able to look at that and see areas where we can improve in the airway realm. And that will be, again, about a year that we'll work through that project, and then we'll release the collective learnings from those projects and recommendations on how to implement in agencies. We also have monthly meetings where we just collaborate and talk to people about how to implement these measures in their agencies. So any of our agency members can hop on those meetings, or any of our individual members, really any members, and you know, work collaboratively with us on how do we implement, how do we make these things happen. We just usually share some of our challenges, some of our successes, and it's a really good, positive, helpful community. We also have a Prodigy channel on the Prodigy LMS, which is this link, where you can go and watch any of our webinars. We try to take a measure or so a month and do some type of education around that measure, why it's important, tell a story about someone who's had successful improvement efforts with that. And some of our work that's coming up, we just barely started working on a panel for MVC trauma care. We talked a lot about that these last couple of days and post-crash care, and we want to work with that group to look at performance measures around those efforts. Sedation and agitation, ketamine, some of those other issues that have been coming up in the news. We feel like that's a really important one to start looking at how can we support efforts to improve how we care for those patients and safety around that. We do measure maintenance every single year. So we look at the different measures and make sure that they're still up to date, they're still relevant, that the science behind them is still important and accurate. And then we put out calls for new measures. So we'll post to a lot of different associations and groups and say, hey, if you have any new ideas for measures, let us know. And we go through those every year and look at the ways that we can add things to our measures that are meaningful. We're also working on refusals. So there's been a lot of evidence that has come out that we're missing things like posterior strokes, or when we're getting refusals or leaving people on scene, especially with the lift assist kind of patients. So we're looking at how can we write things around that so that these patients are getting transported appropriately. A lot of times when those patients have to call back, they're more likely to be admitted, to have more serious issues and to have poor outcomes, including increased risk of mortality. So we feel like that one's really important to start looking at. That's on our radar right now. And we have our user group. We're trying to help people learn how to dive through data and do statistical analysis. And we also have a measure analysis and research idea submission committee. So we have an annual report, which is actually going to come out on Monday. So keep an eye out for that. We'll blast some things out on those channels. And this one is going to look at airway in detail because that's what we're really working on right now. But also we're just going to do these yearly to look at what are poor performance areas that we can work to improve nationally. So why is all this important? We want to make sure that all that data that we're collecting, all those boxes that we have people fill out are meaningful, that we're doing something with that information that's going to help patient care. That's the biggest reason behind all of this. We want to make sure we don't just have somebody digging through a pile of charts doing review and nothing else. That's the old way. So we want to really focus on what types of things do we need to review. We want to be able to use data and technology to focus our review so that we can then have time for performance improvement. So how can you get involved? Your state can become a member. You can become an individual member. There's the link right there on how to do it. We would love it even if you don't join, that you follow us on social media just to keep abreast of the things that are going on. And Eric said that he wanted to give me money. I remember you all heard him say he wanted to give me money. So hopefully we'll see a lot of increased funding and increased projects coming up in the next few years. But any of those social media channels, we're pretty good about posting things on, and we'd love it if you would follow us and join. Is there any questions? No? Okay. Well, I will be around the rest of the day. So if you do think of something pops up, pull me aside. I'm happy to chat with you about what we're doing. Thank you.
Yeah, thank you, Brooke. And NEMSIS is very committed to tracking with NAMSQA. You want to switch up? Okay.
Good morning, ladies. First of all, good morning, ladies and gentlemen. It's nice to see you all this morning. I hope you had a great time last night. You enjoyed yourselves. I heard some stories, good stories, some I'm proud of, and some I'm really proud of. So I'm glad you had a good evening. We're actually going to switch things up on play a little bit here this morning with the order of speakers, and we do this to him quite frequently in the office too. Brooke mentioned funding for NEMSCO, and she's right. I mentioned with our traffic incident visualization project, we look to them to develop the metrics and things from that. And really, it's just a matter of getting the information out about NEMSCO, about how powerful what they do is and how it can be used in your organization. And that goes from the agency level to the state level, even to the federal level in my office. So I am really, even though they were originally funded out of NHTSA, I am introducing them to DOT and the Secretary's office and the National Center for Statistics and Analysis, and trying to get people to use them in the role of metrics development. So when we talk about NEMSIS projects, I look to NEMSQA as the people to develop those things and not our particular tax. So that's how I see us working with NEMSQA in the future. And I hope that plays out to all the other NGOs, whether that's FICOMS, NEMSAC at the federal level, or NAEMT, or NAEMSP, or all the other NGOs that involved in EMS and fire as well. So if you have questions about NEMSQA, please, please, please talk to Brooke.
All right. Good morning, everybody. Thanks for hanging with us here and getting through this Friday with us. It's been great talking with everybody. I'm just going to cover real quick some of the grant funding things that we have on our website for you guys to follow. Some of it can be applied to like post-crash care stuff, kind of different records collection things. So if you go on the NEMSIS website, pardon me while I try to navigate while not on the screen, go to using EMS data, go down to NEMSIS 101. And then scroll down. It'll be under state-specific tools. Go to the general grant application information. So it's last was updated, looks like back in May. Just note that the grants that are going to be on this page, they're currently closed, but most of them reopen sometime at the beginning of this next year. A lot of the grant funding that's available through this or through these grants, it'll be so next year, 2026, and then some of them still roll into 2027 as well. So this all falls under section 402 and 405, just under highway safety programs. If you're looking for, again, like post-crash care, trying to improve records collection, if you're trying to do like records integration with, let's say, like your state crash reporting, law enforcement crash reporting, for the section 405 is a great place to do that. There's a couple opportunities there. Amber from Colorado actually had applied for one of those grants, and I'm waiting to hear what the results of that are. So once we have the end of that story, we'll definitely make sure that it gets shared. And then also under the section 402, one of the key things in there they say is to improve records and also in emergency services. So I guess it's kind of a broad topic. Eric likes to point out if you go to, I think it's on here, I don't remember, but it's the guideline number 11, and it kind of lays out all the things that when applying for grants, NHTSA likes to see as far as EMS, right? Kind of the different things that they want to see in there. A couple other grants, kind of my favorites, if you will. We can keep scrolling. Actually, I'll click on the page. Oops. So safe streets and roads for all. This is a really good one. I have a couple different presentations made up for this one. And this is for public public entities, so governmental entities, county, state, if you have some sort of like safety planning committee, et cetera, there's a lot of funding available. There's been some pretty neat things done with it. Also, for private entities, private businesses specifically, is the Small Business Innovation Research Grant. And so that, excuse me, under there, it just kind of shows the things that you can use that the grant will fund. They want to see basically innovation, technology innovation. How is it helping make the roadways safer? And different things like that. So vendors in the room, this might be something that you might want to look into if you're looking to do some sort of data stuff there. And then on page 10, goes through a little bit about the SMART grant, strengthening mobility and revolutionizing transport. And after having read through this grant, having read some of the success stories with this grant, some of the things that were done with it, this is absolutely my favorite. There's some organizations out there that they're doing like delivery of AEDs, medications, and whatnot with drones if they can't get units to a call fast enough. This might be a good one if you're looking at using drones for delivering blood products to a scene, perhaps different things like that. Again, they want innovation. They want to see how it's going to help your community, your area, make things safer, reduce fatalities. That's the big thing, is reducing fatalities. So those are some of the things. If you go to our website, you can kind of click through those. There's a bunch of links. There's tons of webinars to watch. And then there's other resources that it'll break down a little bit more detail what the different grant things are, what's available, what information there is. And also, I encourage you, if you're going to apply for grants, just make sure you find someone to kind of bounce ideas off of. When you're filling out the application, have someone look it over for you, make sure it makes sense. It doesn't have to be an 80-page essay about what you're doing. Concise, to the point, clear, make it obvious kind of what your plan is, that sort of thing. Any questions? Offhand, probably not, but if you do. All right. Eric?
Just to give you a little background, remember when you're applying for these grants, the key ticket here is transportation. Look at your grant funding source. Cardiac stroke is not necessarily highly on the list for these grants unless you can tie it to mobility in some way. So think about that. Also, I think if there's one key critical piece in this, it's making sure you have a good relationship with your highway traffic safety office. And I know some of you I've talked with have phenomenal relationships and a great history, and others, not so much. So if you don't, please reach out to them, get to know them. If you need help with who they are, if you need help kind of smoothing relationships, please let us know. We're happy to do that in our office. Max Severai, Jeremy, myself, and others have good relationships with our regions and with our states. We're very happy to do that. The other thing is on this document, and then just in your discussions with the highway safety offices, think about what's realistic in terms of funding. Don't ask for $10 million if you're the Rhode Island Highway Traffic Safety Office who has a smaller budget than, say, California. Think about what reality is here, folks. Also, talk to the people that have gotten grants or received grants. Some of you in this room have been successful. Think about what you're asking for the task that you're asking to be completed. For example, interoperability at your state level to hospitals or something. Is that a $500,000 project or is it a $10 million project? Remember that these highway traffic safety office folks, they get together and they talk. So if Brian asked for $500,000 in Alaska to do something, and Amber in Colorado asked for $3 million to do the same thing, is it scalable, or did Amber just ask for an unrealistic amount of money? Think about it in those terms. You're not working in a vacuum when you're applying for these grants. As Casey said, these are not huge federal grants to write up. Some of these have been awarded on a 2.5-page document. So don't think that you have to do 60 pages in triplicate and fill out, in this font, no margins exceeding 1 inch or something like that. It's not that way. It really isn't. And if you haven't asked, time's running out for the bipartisan infrastructure money. I would tell you to also think about the fact that DEA has said many times there's unspent money each year, and there has been. So think of hundreds of millions of dollars sitting on a table that no one really asked for. So think in terms of what big projects could you ask for if you wanted to ask for something really big and put something together. Think in regions. You don't have to just work in your state. Maybe you and the state next to you decide you're going to do the same project and submit it through your states, but sell it as a regional approach. Those types of things are looked highly upon as well. If you have questions, please reach out and ask. We're happy to help work with your office, with your highway safety offices. We're happy to review things, and the document that Casey put up there and some of the information for the TAC has already been written for you. What is NEMSIS? What is the trauma registry? We've given you great descriptions of those, so you don't have to think about writing that. Don't be shy and bashful about these, folks. The money's out there. It may never come again in my lifetime. Questions, comments, concerns? Sir, Jay, how you doing?
Good. Do you know how many EMS offices have received funding by chance?
Okay. I don't. Max could probably get you to a number that's pretty close. I don't track that. I really don't. I have examples that people have sent me and said it's okay to share. So things like that. In fact, I had an ask from the West Coast meeting last night, and I sent them to Max and Gam, and I'll be sending them some information tonight. Now that's for Monday morning. So if you give me like a couple days notice, that's good too. But I don't know an actual number. There have been projects posted through different public media, and we try to send those out through our Google groups when someone is successful. There has been, like in the Safe Streets for All, I believe it was several $1 million for a long-term approach. There's been some sensors put in ambulances that was for several $7 million. There's been quite a few success stories for a significant amount of money.
There has been some good success stories. There's been some rather negative events that have come on. I know some places are, and I know we've talked, but I'll just bring this up to the group. I do apologize. This may be an ugly concept to some people. I think we need to sit down and join forces and figure out how to split that money in those grants to turn around and says, we have offices that are not getting any of the money. We're flat told that we have other priority projects. You're not in there. And I know we need to work with those people. I'm friends with the people. But when we're told that, now we need to take a different path to turn around and come up with a way to change that grant to turn around and says, hey, look, you haven't shared. We need to split the pot. We need to come to find out some way where state EMS offices can get some of that funding that hasn't been able or is being left on the table and get that out to the agencies. And I don't know how exactly to go about it, but whether we need to go through political people, we need to come up with a solid voice. I'm just hoping that the message can go back through NHTSA that says, hey, there's some unhappy people. They're not getting funding on this. We need to find a way to resolve this. And the only way I can think of, we need to split that pot. But I'm open for other suggestions. And I know I'm putting you on the spot, Eric. And by the way, I do want to say my support for Gam, you, Jeremy, and Clay in the office, stuff like that, is 110%. So it's not directed at you. It's directed at the people writing the grants that we can't get them to acknowledge us.
So you're spot on. I don't disagree with anything you said. The frustrating part for us in this grant process, many of you may have heard of percentage funding, to where someone looks at the amount of money that we spent on NEMSIS data And that's a percentage of the amount of money that we need because that's what's related to motor vehicle crash. So they look at a million they look at a million NEMSIS records and say we're funding 10% because 10% of the calls were traffic crash related. And we've done our very best to eliminate that concept and thought within our office, but I think it still exists in a few states. So there's a percentage one that's concerning. When you hear that, please let us know. The negative cases that Jay is referencing, we want to know about those too. And Gam and Jeremy and myself will sit down with that office and do everything we can do to explain why this most certainly isn't a national roadway safety strategy. NEMSIS is very clearly lined out as one of the key elements of that strategy. So there's no reason that it shouldn't be funded. And if that happens, let us know. The only thing I ask is provide us with what your request was. Before I go to battle, I want to make sure I understand that you weren't one of those people that asked for money to paint ambulances purple or to put new helicopters all over your state. Things that aren't realistic. If it's within the realm of what the grant opportunity is, there should be money at this point to fund those things. So please let us know those and we'll do whatever we can. I will say one voice for all of you speaks louder than Jay just stomping his feet saying, why didn't I get this money? So the SEMSO data managers as a group, as a whole, however you decide to proceed, I can't make that recommendation.
No, I appreciate that. And yeah, we couldn't even get to the point that says, hey, we want to fund our trauma system. We want to do some education. It just got flat denied straight out.
I will, this is non-DOT, but I will say, I've said this at the state data, the NEMSIS meeting in Pittsburgh, and I've said this in subsequent meetings where all of you are represented. The cost of what we're talking about doing is going up exponentially each year and is not going to go down. So the funding to keep these data systems in place, the connectivity between all of the different things that are out there, that cost is real. And being able to explain that cost in your grants and make it clear what it's paying for is also critical.
Can I step in just a minute here, Eric? The other thing too, one of the strategies that I went over in the agency forum on Tuesday for applying for grants, use data to leverage your grant applications, right? We're all data people in here. That's what we do. That being said, obviously on the state level, you all have access to your own stuff. But if there's anything, a project you're trying to get funded and you could use some other data statistics, what have you, from a national level, please contact us at the TAC. We can absolutely help put something together for you. I don't know. I'm a nerd, so it's super exciting to be able to do stuff like that. So.
Excellent. Thanks, Casey. Any other questions? Grants, funding in general? Awesome. Jeremy?
All right, good morning, everyone. I'm going to be brief. I have a couple of things I just want to mention. I have a few questions and just want to gauge folks' interest. If you do have interest in any of the things that I'm going to mention, you can just reach out to Clay, reach out to the NEMSIS TAC, reach out to me or Eric directly. The first one is on FARS and NEMSIS linkage. So we've heard from a few of our state FARS analysts that they have really good relationships with the state offices of EMS. And so thinking about the presentation that Jay and Clay gave about the UUID linkage that they're doing with the trauma centers, we've been thinking about, could we do something similar, but with the FARS data? Folks might be familiar with MUC. MUC now has an electronic placeholder for the NEMSIS UUID. And so if a state or a vendor who provides a state EMS data repository was interested in working with a FARS analyst, where that FARS analyst would kind of act like the trauma registrar, where maybe they could query the state EMS data repository and pull out a few, like maybe 5 elements, including the UUIDs, so that they can move that into the FARS record. If anyone's interested in working on something like that with us, please let us know. And then just a couple of research and analysis items. I think we talked about just the lack of data that we have at the national level in terms of our ability to identify patients that have received blood. So it was great to see everyone kind of come together and come up with some solutions there. But if there's any states or vendors who currently have a good deal of data, that they're able to capture via some of those custom fields, if you have an interest in working with us to see for motor vehicle crash patients, what are some of those intermediate outcomes when we know an MVC patient has received blood? What are we seeing in terms of their improvement in GCS, their improvement in the shock index, some of their other vital signs, so that we can take that and kind of show it to our leadership that, look, we can see at least, we might not have the data to show improvement in mortality, but we can at least show that these patients are improving in the field, maybe compared to other patients. That's also something that we're interested in. I think the endpoint there would be to work with us to maybe publish like a NHTSA research note or get something published in the in an academic journal. And then similarly on extrication research, I'm not sure if Gam mentioned this in his presentation, but we know in our FARS data for vehicle occupant fatalities, 25% involved extrication. So we've been thinking internally within the office about, is there something else we need to be doing in this space? So we've been doing a little bit of research at the national level with the NEMSIS data, looking at cases where we have an extrication delay, on scene delay due to extrication documented, and seeing what impact that has on time from scene arrival to life-saving interventions. So if you do have a documented extrication scene delay, is it taking longer on average to have a tourniquet placed or to have an IV started, to have CPR started, things like that. And we are seeing that obviously it has an impact. So I think if there was a state that was interested in doing some research like that with us, we don't have the narrative at the national level, so it's a little bit hard for us to kind of validate what does scene delay mean, because there's not really like a standard around that information. But I think if we had the narrative, we might be able to do some validation to kind of better describe what a scene delay, an extrication scene delay is. And also related to that, I don't know if folks are familiar, but NEMSP recently published a pre-hospital trauma compendium management of the entrapped patient. And so I think they had like 5 or 6 recommendations in there. So I think it would be of interest for us to kind of look at those 5 recommendations and see, is there anything in a state EMS data repository? Is there anything in the national repository where we can kind of characterize whether or not our EMS clinicians are performing those recommendations? And so if you have interest in partnering with us on any of those things, again, the point would kind of be to publish it in an academic journal or as a NHTSA research note. If anyone has any thoughts about any of those things, happy to answer any of your questions, or as I said, you can always reach out to us.
Thank you, Jeremy. Thank you, Casey and Eric.
Our next presenter, Alan Aguayo from the National Registry of EMTs. We're going to be talking a little bit about the National Provider ID number and how we think it could be utilized within NEMSIS and our overall data activities.
Good morning. Full disclosure, I didn't know until yesterday evening that I was going to be presenting this morning. So if I look like I'm unprepared or you hear my voice shaking, that's exactly why. I didn't know I was going to be here. But anyway, I know a few of you, but there are many of you that I don't. My name is Alan Arguello. I'm the Chief Operating Officer at National Registry. I've been with the organization for about 8 years in a variety of roles. I've been the COO for 2 years. So we're going to talk about the National EMS ID. But before I do that, we're going to go, hold on, make it work. All right. Before I talk about the National EMS ID, I kind of want to talk about the workforce in general. And that you see that quote at the bottom that says it's a distribution problem. Often when we think about workforce dynamics and when we think about the availability of EMS clinicians, providers, whatever nomenclature they're allowing us to call them, you always hear, well, it's not a workforce problem, it's a distribution problem. I have a very big issue with that because I've not found anybody who has used that argument with me. No one has been able to tell me what the distribution is supposed to be. And if there's somebody in here who can, I implore you to raise your hand. A hand never goes up because it's such a terrifying question. What should the distribution of EMS clinicians be in the United States? No one knows. And there's a reason for that. It's because we have disparate data systems. Data sets are limited. We don't actually have an ability to look at EMS clinicians nationally. We have a great ability to do so at the state level, but nationally we're limited in that regard. And obviously, we don't actually have any true national workforce estimates. If you look at the Bureau of Labor Statistics at the number of EMS clinicians they think there are in the United States, it's way off. It's off by millions. So anyway, go to the next slide. So with the National Registry, what we have is something called a National EMS ID. We say it's something that we have. I only say that because it's generated by the National Registry of EMTs as soon as somebody's certification is granted and when they create an account with us. But we see a unique national ID for clinicians as a solution. It could function similarly to the way that an NPI number works for physicians. And it's as a long game strategy, if it's tied into state level educational licensure frameworks and patient care, we think that we'll have the ability to track EMS clinicians nationally. Now, when we say track EMS clinicians, that's a very scary term because it assumes that we're tracking one individual. I don't ever foresee a future wherein the national provider ID is elevated to the national level where we're looking at the individual performance of an individual clinician, because that's nuts. That's not the purpose of the number. It's to generate insights into the workforce and so that we understand those dynamics. And we think that the pathway to rigorous population-based evaluations to address the health and wellness of the whole workforce is via this EMS ID. So a little bit of background, where it came from. It was launched in January of 2019. Its purpose was to duplicate licensed providers for the Emergency Medical Services Licensure Compact. So most people here know how the EMS Compact works. It's a mechanism to allow a multi-state privilege for folks that have more than one license. The issue with that is that there was an issue deduplicating providers. I go by a few different nicknames. I'm not going to name them for you, but one of them is Al. But my actual name is Alan. My father calls me Alino. I have all these different nicknames. Similarly, I've miskeyed my social security number on things multiple different times. I've miskeyed my address, and the ability to actually deduplicate me as a provider was limited before we had the National EMS ID. And so its use within the EMS Compact actually helps us to synergize those multiple licenses, those multiple license numbers that people have. It's auto-generated by the National Registry as soon as somebody creates an account with us. And so this isn't just for those that created an account after January of 2019. Every clinician that has ever created an account or been certified by the National Registry of EMTs has a unique identifier associated with them. It's not their National Registry number because, with a National Registry number, I can tell something about you. It's either going to start with an M, it's going to start with an E. I can tell you're a paramedic. With the National EMS ID, it's just a completely de-identified number. And it never changes. It follows you from cradle to grave. From the second that it's generated, you're going to have the same National EMS ID from the point at which you become an EMR, assuming you go from EMR to EMT, AMT paramedic. That never actually happens. But I haven't found a better analogy for cradle to grave. So if somebody here wants to come up with something that's not so morbid, all right. So some potential uses. Many of these are pipe dreams. I know I just got through talking about workforce, but these are potential, uses of the EMS ID. You have the ability to evaluate educational outcomes at all certification levels. If you're tying in this identifier to the education programs and the states that people are attending, you can look at how the clinicians that graduate from certain regions, certain programs, certain states are performing with their actual provision of patient care as captured in NEMSIS. You can, I just simply say resource typing, but you can actually verify EMS clinician practice authorization. For those of us that have multi-state licenses or a multi-state privilege, or if you have a license in multiple states or different credentials, often there's no place that actually synergizes all those respective credentials for you. And so we see the CMS ID as being able to do that. Similarly, tracking clinician exposure histories, such as hot and warm zone operations, all the various insults that EMS clinicians undergo every day. And when we think about the longitudinal assessment of fire and EMS, this is a very, very long study that the National Registry is helping to lead with some other organizations. Our ability to actually longitudinally assess the insults, injuries, and exposure histories of EMS clinicians, and in addition to the health effects that the profession has on these individuals, is going to be contingent on our ability to actually longitudinally track these individuals. Tracking continuing education, this is something that's already done. If you've gone to EMS World, or if you've gone to GEMS, you'll notice they ask for your national EMS ID now. They're not always asking for your national registry number, because it turns out there are lots of people that don't have their national registry certification. Let me know who you are so I can talk to you after. Further, making estimates to enhance disaster preparedness through disaster modeling linked to EMS distribution, actually understanding where clinicians are, and actual practicing clinicians. There's a difference between me and a lot of other nationally certified paramedics. I haven't touched a patient in 12 years. I have an active license and an active certification. Tomorrow, I could just as easily go and walk into a disaster zone and kill everyone. That wouldn't actually happen, but we have the ability in the future to be able to do this. And further, the workforce dynamics, I've been talking about that since I started. So this is usually the place where I pause for questions, if anybody has any. I'm a fast talker. I tend to move quickly. I also appreciate that y'all are like 3 or 4 presentations away from going home, and they've already given out the prizes. So I appreciate everybody bearing with me. So if I can go to the next one. All right. I've got a use case from the state of Minnesota. Dylan Ferguson, the executive director of the EMS Regulatory Board, did give me permission to use this information, but I think this is a great use case. So a while back, the state of Minnesota, they tied in their licensing system into their actual EPR system to try to understand the provision of patient care in their state. So sorry, I forget there's a microphone. Sorry, Clay did that yesterday. So they were trying to look at the provision of patient care in their state versus those that actually hold a provider license. And over the course of a year, of all those that were, oh wow, like Bob Barker. Hey. So if you look at the number of EMS clinicians that had no PCR activity, this is out of all of the licensed clinicians in the state. There's almost 5,000 licensed EMS clinicians in the state of Minnesota that did not touch a patient over the course of a year. And the way they did that, obviously, is tying in their licensing system along with looking at their EPCR records. But the reality of it is that's a lot easier than it sounds. And the way that they did that, I'm back at this mic now. They don't actually have a link between their licensing management system and their EPCR system. The way that they did that was they made sure that the state license number was on both their license management system and within their EPCRs when they fill out their patient care reports. And they did a bulk export from both systems. They created a tabular database in Microsoft Power BI, which is the Microsoft app that creates data visualizations. And obviously, they had some issues with data quality, right? You have a lack of data certification numbers. I'm sorry, with a lack of certification numbers, we call it license numbers, within the EPCR report. So they forgot to enter their license number. And oftentimes they enter the incorrect number when doing that. Now, I will say, when it comes to this particular use case, this is stellar. Like the work that the state of Minnesota did to actually understand. Is anybody from Minnesota in here before I'm taking credit for your work? Yeah, this stuff rocks. Like this is excellent work. And I actually use it as an example all the time. It's absolutely stellar work, but I also don't think it should be that hard. I don't think it should be necessary that a state regulatory body have to do a bulk export out of Microsoft Excel to understand all of their licensees to be able to create a tabular database in a third-party system in order to try and generate insights for workforce for their state. I think it's unnecessary. And I think the EMS ID is a solution to help move past things like this. So as a take home, I think we collectively, as stakeholders within the industry, many of us current and former clinicians, have a responsibility to understand what is emergency medical services. And by that I mean, what is the distribution right now? We have the ability to develop better sources of data to actually describe and define workforce challenges. And we have the ability to link education, certification, licensure, and care. And, we're at a place where via the national EMS ID or provider ID, whatever people want to call it, to develop strategies for the retention of our clinicians. Because right now, we put a lot of emphasis on workforce, on educational entry as a mechanism to float the workforce. And it's just reality, right? You see the proliferation and the increase of the use of, high school education programs. But our ability to actually retain individuals comes from being able to study our existing workforce to understand those dynamics. And so that's kind of my call to action here. So that is the end of my slideshow, and another opportunity to ask questions if you have any. Sir.
I didn't think we were doing this today with the microphones.
Yeah.
Was there an attempt to capture paramedics or EMS professionals who are working in a hospital setting or in a private setting, but not on an ambulance?
So is the question you're asking related to the work from the EMS regulatory board?
Yeah.
Somebody give the mic to somebody that works in Minnesota as part of that research, because that question I can't answer. But you're asking an excellent question, because everyone here knows that we have nationally certified paramedics who, in some states where paramedic is a protected term, wherein you can only be working on a fixed rotor, a fixed wing, rotor wing, or a ground ambulance. In many states, there are no stipulations about where the term paramedic can be used. And so we know that there are nationally certified paramedics working in hospitals. We just have no idea where they are. And so, yes, I can't answer specifically about Minnesota. Oh, yeah, exactly. Yeah, no, that's a great question. Thank you. Anybody else? Sir. I got a mic up here, but it'd be weird to run over with it.
Adam Rovang with Washington State.
Sure.
I do a lot of work with our EMS licensing program to summarize license numbers. Can we get access to this sort of data for that purpose, like tracking EMS license numbers in our state to get a better sense of the workforce?
So I want to make sure I understand the question. So you work for the state office.
Yes.
And you're asking about getting access. So the information you want access to, is it the Minnesota information, or is it like, are you trying to track
my state's information in Washington State, just to not even anything related to names, just the number of providers, because they seem to have trouble tracking that.
Yeah. So that's it's always a state by state issue, and it's easy for me to say yes, because the answer technically is yes. We can give you from the National Registry's perspective, we can show you the national EMS ID of everybody in your state who has ever been certified by the National Registry. And in the state of Washington, where national certification is required to get an initial license, I would make the assumption that most people have a national EMS ID. But the ability to actually look at the provision of patient care within the state is going to be contingent on that number, or the license number by the state, also being used on the EPCRs. That's going to be the biggest gap. And so we can connect after this and we can figure out how to do that specific to the state. But I think the biggest gap would be, how do you tie in the licensing to the actual provision of care? That's the gap that everyone's got. Perfect. Y'all, I feel pretty good about this for something I didn't prepare for. Hey, look, appreciate that.
So over the next year, after the first of the year, this will be a project we'll be taking to Amber and working with the NEMSIS and Randall and others to talk about the integration and how this fits into NEMSIS and how we can use it with NEMSIS and make sure we're meeting all the requirements for the compact and the things that National Registry has set forward. So just one of our many initiatives.
Thank you all so much.
Thanks.
So I just have one more discussion point with folks, and no slides before I turn it back over to Eric to finish us out. We're interested in continuing our monthly trainings. How many folks have participated in a monthly training with a NEMSIS monthly training within the past year? Okay, great. We're interested in determining if there are other topics that we should be considering for those trainings. We wrestle with the idea of like how many times can we do a schematron presentation, but that is such a complex topic that we feel like that's something we should do annually as new data managers come on, other things like that to deal with kind of some of the hot topics or the topics that perhaps if someone comes in with little IT experience, a little EMS experience, could benefit from. Would love to collect some ideas from you folks in regards to what kind of training you'd like to see come from the TAG for you or staff or your providers within your states. Any ideas? Yeah, Josh.
In the advisory board meeting on Tuesday, there was some discussion about the field level providers as an audience. And, we looked through the list of last year's trainings and there were a handful that were maybe relevant to a field provider. There were definitely a few relevant to agency administrators. But I'm kind of curious about that field provider level, like what people in the room think about, is NEMSIS the right group to reach that audience? And if so, what kind of trainings would be more tailored to that field level audience?
That's a great question. Sundown.
Well, so I think that, Josh, specifically to your question, is NEMSIS the right venue for that? I kind of want to say no off the top of my head, but I would say it's kind of hard to say, other than at the micro level, at the agencies themselves to kind of develop their own training, it's hard for everybody. I think developers can be great partners in developing education, but I think the problem trying to bring it down to the provider level is that the EPCR process is such a granular task level process for most providers that I think it needs to be broken down into such concrete steps that it's very hard to do it from, basically coming down from the mountain of NEMSIS. But at the same time, I do think there's a need for that because the level of understanding and comprehension is not great. Also, you have a delivery problem where, because coming from, fire-based EMS, I would have to say, let's face it, the attention span of your average provider is maybe about 20 minutes. So how do you deliver that? So here would be my suggestion, and this is pretty not well formed, but I would say something like an education toolkit where to empower agencies to provide their own education by saying, here's a set of building blocks, here's some Legos for education topics with maybe some pre-built slide decks that you can insert and then tailor to your own particular practices and protocols.
Great, Sundown. And so your comment, it sounds like you're talking about three different things. One is just letting providers know that NEMSIS exists and why it exists, what it does. Maybe number two was the importance of good quality data. And then maybe the third was kind of motivating, providing some talking about research or other things that are happening because of the good documentation they're providing, something like that as a toolkit.
Well, certainly, but I would say out of those three that you mentioned, I'd say providing the context for it, providing like the reason what the impact of this of NEMSIS is and of the data quality is. I think that's the thing that grounds it most for the provider. I mean, I think that coming from the basically trying to set the basically to answer the why question about why are we collecting this, why do we have so many things, why are there so many elements, I think that is something that does need to be made available. But I think that to try and ground that in what is the potential impact for your community, for the EMS community as a whole, as for the improvement of the of the job itself. I think that's what's most meaningful. So I think that's just basically keep that as sort of like the guide star.
Great, thank you, Sundown. Other comments related to other trainings? How about on the vendor side? Anything more that we could be doing in regards to helping vendors with your relationships with providers or with states? Other trainings we could provide? Keenan?
It's been a long week. I think it was Tuesday that we talked about if there are granular trainings that need to happen and be vendor specific and kind of look and be delivered by our folks. And we wanted it to come from NEMSIS as far as content goes. It would be great if you guys would help with whatever scripting or whatever message you're trying to convey, and then we can take it through our programs to basically distribute it to our folks or get it to our customers so that they can do it like Sundown to get it into their providers' hands.
Yeah, that was a great discussion we had on Tuesday. Thank you, Keenan, for the reminder. I think there's some great kind of integrations we could do there. Any other ideas? Yes, please.
Hey, Connor, Vermont. I think it'd be helpful for, I don't know if it's probably state by state, but at least for new data managers like myself, to kind of go over that grant funding part that was on NEMSIS. Didn't know it existed. Was very excited to see that today. But to kind of best practices, just because when I reached out and was onboarding, I didn't have any resources except YouTube, which was of limited help. So I think that'd be really helpful for me at least.
Yeah, that's a great idea. And I made a note. I think there are some examples of funding that are publicly available that I think that could be really helpful in sparking some ideas for states. Kevin, did you have something?
Yeah, I'm sorry, I didn't catch your name. Who just spoke? Did you take the data managers course? Not yet? Okay, awesome. So I know we talked a lot on the advisory board about making several tracks for education and training. So like ones that would be not necessarily only data managers could take that, but ones that are targeted toward data managers, ones that are targeted towards software vendors, and others that are targeted towards those clinical, those providers in the field, with there being some layover. And so we've put a lot of thought previous to this meeting, but we really appreciate all the ideas that you guys have brought forth so that we can try to tailor some of those educational aspects.
Great. Any other thoughts or comments? Yes.
Hi, I'm Chris Lucas with software engineer for Emergent. Work with Kelly Pithen. I just started working with all of this NEMSIS stuff about 6 months ago. I've been with Emergent for about a year now. And this is all new to me. This was a great conference. I learned a lot this week. It's been really helpful. But I know that when I went to go look at the public training YouTube list and things like that, one of the things for me that was just figuring out where to start, right? So I don't know if maybe a roadmap might be helpful for training, because there are lots of good videos there, and I learned a lot from those as well. But I think in the beginning, I just didn't know where to start.
Yeah, that's a really good thought. And we've talked about organizing that in a different way, right? That might be a little bit more intuitive for someone who's coming on for the first time. Yeah, so Chris is shaking his head. Yes. Yeah, great idea. Great. Any other thoughts or comments? Okay, great ideas. Thank you very much. Eric, I'll turn it over to you for the last two topics.
Yeah, I think we're down to one, actually. Kevin and I were going to talk a little bit more about the education piece, but Josh kind of teed it up to target audiences, which is what we were going to. So I guess we'll just end that with the saying, if you have a specific topic that you think should be like tracks for a new data manager, organization of something that's already in existence or updating it, please let one of us know. You can always email it in to the help desk and we'll get on that. We did talk about this in the advisory board when we did the class for the data managers, or what we thought was targeting the data managers. I think the initial buy was for how many pins?
It was about, I think, around 20 to 30 pins.
20 to 30 pins. And then we've since like doubled that and then doubled that again. So the number of people doing it's far more than we thought. And it's not just data managers. We have all walks of EMS levels in that class. So I think we'll see a lot more of that sort of thing as we move forward. The last thing Clay asked me to talk about today was just to go back over blood transfusion and the timeline for the data requests. So the goal, at least the consensus to where we got yesterday, was we're going to use the data manager's recommendations. Amber is cleaning that up and making sure that goes out. We'll take comments on that, get that back, and then make any edits. Run that by the appropriate organizations to make sure that there's no conflicts that anybody sees, but I think that's pretty much been done. The expectation is we identify the national custom elements and have those available by January 1st. Josh is going to work on the national schematron and have that available, although it will not be part of the national custom schematron until after January 1st. I have that correct, right? I'm looking at Josh. No change on January 1st. We'll make it available so that if people want to adopt that and use it, but it will not be changed until after January 1st. Questions about transfusion documentation? And the reason for doing that is just the timeliness and the need to have this available. Thanks to those vendors who have sent me information about the transfusions you've had historically, and we'll be working with you individually to make sure that we have those captured correctly and it wasn't just a worksheet issue or a documentation issue in that coming to the national level. Any questions about blood or blood transfusion data collection? Josh.
Yeah, just a little bit more on the schematron side of things. So, if we revise the national schematron schema, that's a version release of the NEMSIS standard. And so that's not happening on January 1st. But I think the request is to provide some guidance about rules that states could deploy. And so we'll just need to gather the requirements on what those rules need to do. What I've heard so far is stuff like if you do this particular procedure that's a blood product administration, then you need to also have a medication that's one of these medications. And maybe we go the other direction too. If you did one of these medications, you need the procedure. I don't know. And what else? So maybe the data managers can get together and help with that and just help us figure out what rules we want to try to develop. We'll go from there.
Other questions? Thoughts? Anything else?
Just to make sure. A quick verification. So today, if you can document blood products as a medication per the current defined list, we're still good. And if it's January when we get the procedure in, then we're still good. Excellent.
Other questions, thoughts? So that's all I had. I'll wrap up and then turn the mic over to Clay to end things. You have nothing else to say? Close it out. Close it out. Thanks to everyone. This is an incredible amount of information. I've said yesterday what a pleasure it is to work with this group, and I truly mean it. The amount of talent in here is remarkable. I look forward to seeing you all at the regional meetings and at your conferences and meetings throughout 2025. If there's something you want us to attend or you have information that you'd like us to come share with you or something you would like to propose as a project, please reach out. We look forward to spending time with you. Safe travels home and take care.